Hi everybody. I was charged with talking about what it's like trying to take care of patients in this system, and I think Beth Ann put it really well, which is that you feel like a failure as a clinician, because you know what your patient needs, and you try desperately to get it, and you can't. And if we want to talk about why there's so much burnout in the medical profession, I think this is a huge part of it. We feel like we're not helping people, and that's why we went to school. So there are many costs to the current system, and that's one of them. So here I just want to point to what David was saying, is people need care during serious illness when they're at the end of life, like in the last few months of life, and they can get that through hospice. They need serious illness care during a crisis when they're in the hospital. They break a hip, they suddenly become short of breath, they have an acute MI, they need hospital care and support. And right now you can get palliative care in the great majority of large hospitals in the US, and you can get hospice. And I just want to point out, not to be constantly criticizing the US system, we have by far the best hospice access in the world of any developed nation. And not to take it for granted, because it really does provide urgently needed support at the most vulnerable time. But the gap, as David pointed out, is huge, and it's in the middle, because the great majority of people with serious and complex illness are not hospice eligible. They're not dying. They're not in the last few months of life. They are living, and living for a long time, with serious and complex illness. And they're pretty much cared for in their doctor's office. They may get some home care through a certified home health agency. They may get skilled nursing facility care if they need rehab. And if they have Medicaid or money in their pocket, they may be getting long-term care in a nursing home, although it is still the case that most of our patients say they'd rather die than end up in a nursing home. So this is the question, is how do we fill this gap? And what I'm going to do is walk you through part of one of our courses. CAPC has a bunch of online courses. This one is the dementia course, and we've started using graphic novels to help teach about this. And it actually sounds sort of similar to Ralph and Patricia's story. So it's 5:47 in the morning, and this man wakes up to hear his wife calling out for help. "I'm so tired, she didn't fall asleep till 3, please let her go back to sleep." And she's climbing out of bed, and he's thinking, it's another day like yesterday. I don't know how I can do this again. She goes into the bathroom, she falls, she's screaming. He calls the doctor's office. The doctor's office is closed now. If this is a medical emergency, hang up now and call 911. And so he's thinking, what should I do? Is this an emergency? I can't get her up. And she's panicking. I can't watch this any longer. He calls 911. Okay. And there was a whole article yesterday in the Kaiser Health News about how we don't know if that ambulance is in network or not, and how he might get hit with a $8,000 bill for an ambulance that wasn't in network, to take him to a hospital that might not be in network. So here's the hypothetical primary care doc, and it kind of reminds me of what Beth Ann said about her own sense of helplessness. I know they keep showing up in the ED in the middle of the night, but what can I do about her back pain? So the reason she gets crisis is she has spinal stenosis and arthritis. It's not a terminal illness, but it's very disabling and causes very severe pain. The orthopedist and the neurologist say surgery is not an option, Tylenol doesn't work, and her diabetes doctor says she can't take anti-inflammatory drugs because of her kidneys. And of course, we can't use opioids in someone like her, demented, frail, falling, etc. So Martha and Bernard spend the morning in the ED, and Martha is admitted for a fecal impaction. After discharge, Bernard comes to Dr. Jones's office for an appointment. He says her agitation is no better since starting the laxative. She is still awake much of the night, moaning and crying out. He's exhausted, and your staff is worried about both of them. Martha is not sure he'll be able to get Martha into a cab for the appointment, and the team is arranging for an ambulette. Bernard tells you when he gets there, I'm at my wit's end. I have forgotten to give her medicine several times. Yesterday, I fell asleep on the couch and woke up to find her on the floor again in the bathroom. She's restless and upset, and neither of us can sleep. After determining that Martha really can't participate in a conversation about what's important to her, you talk to Bernard about what she cared about most and what he thinks she would have said about what's happening to her now. Bernard tells you that Martha was terrified that she might have to go to a nursing home and made him promise repeatedly never to put her in a nursing home. He said, Martha just wants to be at home with me. How many of you have had your parents make you promise not to put them in a nursing home? It's a terrifying prospect for people. Dr. Jones continued, I've sent home care in there a few times, but they just discharge her after a few weeks because they say she doesn't have a skilled need. So the criteria for Medicare Certified Home Health Agency are two: you have to be homebound, and you have to have a, quote, skilled need, not a custodial care need, such as nursing care to teach about insulin or wound care or PT/OT type therapies. And home care is reimbursed on a single episode basis. So the financial incentive for the home care agency is to get the person discharged because they get paid on an episode basis. She's not even close to hospice eligible, and Bernard won't talk to me about nursing home. What am I supposed to do? Okay, so the fact is there is nothing he can do in the current financing system, and he's aware that he's failing the patient. So, these are the options for these patients. For Martha, nursing home's not an option because it's not an option for her and her husband. Subacute, similarly, she doesn't have a rehab indication. She is not hospice eligible because she doesn't have a short prognosis, so no hospice would take her. And so what happens, she gets episodic certified home health agency and goes back and forth between the home and hospital, and that's where her care is focused, simply because there are no alternatives. Now, early on, 2 or 3 years ago, that might have been the most cost-efficient method because she wasn't using the hospital to manage her chronic illness. But now she's using the hospital to manage her chronic illness, and it clearly is no longer rational from an economic or quality standpoint. So as it happens, Dr. Jones is working in a healthcare system that's become an ACO, and that changed things. He saw an email about a house calls program for complex patients in the new Medicare ACO, so he calls the number. And he's able to arrange home-based primary and palliative care for Martha. The house calls teams visit several times a week till Martha stabilizes. Bernard knows to call their 24/7 number after hours if problems arise or your office is closed. Huge issue here, the 24/7 access. Almost all these crises arise after 5 o'clock. And call your own doctor after hours and see what tape you get. It will tell you to call 911 if you're having an emergency. System is perfectly designed to get the results that it gets. The house calls team calls you, Dr. Jones's office, to say the refrigerator is empty because Bernard can't leave Martha alone to go shopping. There are no grab bars or elevated toilet seat in the bathroom, and there are loose rugs and electrical wires everywhere. The apartment is a mess, and Bernard says he has not been able to do laundry in over a month. Now, you would never know this, Dr. Jones, right, because you don't make house calls, right? And maybe when the certified home health agencies were in there previously, they tried to do something about this, but then they discharged him. So there was no ongoing hovering or support for these issues that are the reason she keeps ending up having back pain, right? She can't stand up from the toilet because it's not elevated. She has a low couch that she can't get up from without getting back spasm. There are all these simple things that should and could be done in the home that would have obviated the need for 911 calls in the middle of the night. That didn't happen. Your office arranges for a home health agency, and they do the home safety evaluation and put in the grab bars, the elevated toilet seat, one of those chairs that helps people stand up, and a hospital bed, and they arrange Meals on Wheels. With their permission, the team calls Bernard and Martha's church and arranges for a friendly visitor program because their church has a program for shut-ins, and most faith communities do. But that requires having a team that has the time and knowledge to do that outreach into the community and pull the resources in. And you heard from Ralph how there are a lot of barriers to pulling those community volunteer resources in, including pride and retaining dignity. But they provide companions so Bernard can get out to shop and see his friends. The church sends a car to bring them both to church and lunch and then home again on Sundays. After talking to a palliative care colleague on the house calls team, Dr. Jones okays trying a little morphine. So he needed a colleague to colleague reassurance about the monitoring that would take place and the hovering that would take place in order to feel safe enough to put a frail, demented, high risk for falls older person on an opioid. But without doing that, the pain crises, the question is what's safer, going back and forth to the hospital or a trial of opioids? So they try Martha on low-dose opioids at bedtime as she continues to moan and cry out in pain at night, and a daily bowel regimen. Bernard knows when and how to administer it and to call right away. So then this is the follow-up to that. Again, 5:47 a.m., help, uh-oh, her back must be bothering her. If I give her the pain meds, she might feel better and stay in bed. And I can't forget the laxative that goes with it. Sigh, it's so early. I hope she takes her pills, but at least it's Tuesday. I have my card game today. Here you go, honey. I got you the ice cream you like to eat with your meds. It's Tuesday. This afternoon, the lady from the church is coming. Doesn't that sound nice? It's going to take a while for the medicine to work. I'll just put on one of her favorite records. 30 minutes later, they're both asleep. When you next see Bernard in the office, he's gained weight, he's smiling, he no longer appears down and depressed, he is sleeping at night for the first time in months, and so is Martha. The OT from Home Health asked Bernard about Martha's favorite music, and they downloaded Broadway show tunes onto her iPad for her. She sings along with great gusto. Bernard is happy to see her taking pleasure in life again. He tells you, I have my wife back. So 18 months later, after no further 911 calls or ED visits, the house calls team talks to Dr. Jones about hospice eligibility in dementia. And he had never referred a dementia patient to hospice, only cancer patients. But she's begun to refuse food and is now choking on food and losing weight. And so he's considering a hospice referral. So the before and after. Before Dr. Jones saw the notice about the ACO covering home-based primary and palliative care, 4 911 calls, 4 ED visits, 3 hospitalizations, hospital-acquired infection from a Foley catheter placed in the ED, functional decline, enormous distress for both the patient and the family. After the house calls program was put in place, much better pain management, 24/7 phone coverage, obviating the need for 911, support for Bernard, Meals on Wheels, friendly visitor program, home safety supports, no further 911 calls, ED visits, or hospitalizations, and a timely referral to hospice 5 months before death and a peaceful death at home. What made this possible? As David said, a value-based payment model made it possible. And in fact, if you look at the published data on home-based palliative care, they are almost all sponsored by an ACO. So the ACO at Sharp, which was a pioneer ACO in San Diego, developed a home-based palliative care program, very similar outcomes. ProHealth, which is a multi-specialty 900 physician practice on Long Island, and a practice-based ACO sponsored Dana Lustbader's home-based palliative care program, very similar outcomes. So when you have the financial alignment with the right care, it actually can occur and make a huge difference in meeting patients' needs. And that's where this middle gap is, we hope, going to be filled. Thank you.